And now we're going to move on to our next speaker, Dr. Tanaz Kermani. Dr. Tanaz Kermani is a vasculitis expert and associate clinical professor in the Division of Rheumatology at University of California, Los Angeles. She's the founder and director of the multidisciplinary UCLA vasculitis program. She's a full-time clinician, and her research interests are in large vessel vasculitis. She has several ongoing research collaborations and has numerous publications related to her research. Many of you are familiar with Dr. Kermani from the regional conference on the West Coast a few years ago, and also some of the recent international symposia. So welcome, Dr. Kermani.
Thank you, Jen, and thank you everyone for being here. Our topic is steroids 201. Make sure that you can see my screen, yes?
Yes, we can. Thank you.
Thank you. All right. So we're going to go over the role of glucocorticoids, or so-called steroids, in vasculitis, including the dosing that we use. And then we're going to spend some time talking about some of the side effects, including how to manage them. And the focus is going to be on the infection risk, which is, of course, very relevant right now with the pandemic, but also bone health, adrenal insufficiency, and then dental issues as well. So our goals in treatment of vasculitis is really to suppress the immune system and to manage the inflammation. What we want to do is prevent further organ damage from occurring related to the serious inflammation in the different organs. We want to achieve and maintain remission. We would like it to be no disease activity, but depending on the form of vasculitis, it may be low disease activity. And then also identify and treat flares early. So oftentimes we can get people into remission, but then things can flare up again. And of course, monitoring for side effects from all of our medications. So a brief history of steroids. The picture on the right is Dr. Hench, the founder of the Division of Rheumatology at Mayo Clinic. And then on the left is Dr. Kendall, an endocrinologist at Mayo Clinic. And Dr. Kendall identified something he called compound E, which turned out to be cortisone. And Dr. Hench used it to treat a first patient with rheumatoid arthritis. And this person was severely disabled from their longstanding rheumatoid arthritis. And the minute they were treated with this cortisone, they were able to walk and they had a miraculous recovery. Since then, we've noticed that there are a lot of side effects associated with steroids as well, but they did receive the Nobel Prize in Physiology in 1950 for this discovery. And in 2020, we're still using the steroids for many of our inflammatory conditions, including vasculitis. So a brief overview of the biology. So the adrenal glands are these triangular shaped glands that are above the kidney, and they are the ones that produce the cortisone or cortisol. There's two different parts of the adrenal gland, the so-called cortex, which is the beigeish color over here, and then also the medulla. And the cortex is where cortisol is produced. In general, our body makes about 5 to 30 milligrams of the equivalent of prednisone a day. And the curve on the right shows you the time of day down here, and then how much cortisone is produced. And our typical body's physiologic cycle is a peak somewhere in the morning, somewhere around 6 to 9 a.m. And then as the day goes on, the levels of cortisone drop and they are almost undetectable by midnight. And this is important when we start talking about some of the timing of the medications and also things like adrenal insufficiency. It's also important to note that during periods of stress, infection, the body usually will produce more cortisol than the baseline. This is just to point out that the cortisol production is regulated at multiple levels. The hypothalamus, which is the top panel, and the pituitary gland are in the brain. And they secrete the hormones, the CRH, ACTH, which then stimulate the adrenal gland to produce cortisol. But what's important is there's a feedback loop in these pathways, so that if you have a lot of cortisol, that will give a negative feedback to the hypothalamus and the pituitary gland to reduce some of those hormones that would stimulate the adrenal gland to make more cortisol. And this is important because when you're getting prednisone in the pill form, it does suppress some of these pathways that would normally cause your adrenal glands or stimulate your adrenal glands to produce the cortisol you need. So why are we still using steroids? They really are potent anti-inflammatory and immune suppressing medications. One of the advantages is the quick onset of action. Many of our other medications can take a few weeks or months to work, and in conditions like vasculitis, obviously that would translate into more organ damage, which we do not want. So we want to put out the inflammation as quickly as we can. But what's also important is that none of these things are set in stone, and if you are having side effects, it's important to discuss things with the doctor. But more importantly, do not stop treatment abruptly because of concerns, one, of the vasculitis flaring, but also, as I showed you in the previous slide, when you're getting prednisone, your normal pathway that would stimulate the adrenal gland to produce cortisol can be suppressed, and that can cause problems like shock. So that can be very dangerous. So again, always important to discuss things and not stop these medications suddenly. There's many different formulations of steroids with different potencies and duration of action. The ones that we use in rheumatology are prednisone and something called methylprednisolone or Medrol. The Medrol is available intravenously or pill form, whereas prednisone is only pill form. And then this table here shows you dexamethasone, which we don't use much in rheumatology, but is used by our hematology oncology colleagues, our neurologists, and some of the other specialists. And that's the most potent, so 25 times potency compared to hydrocortisone, which is the weakest of the steroids, and then the potency for prednisone and methylprednisolone, with methylprednisolone being slightly more potent than the prednisone. So the typical doses that are used are the so-called pulse steroids or the IV steroids. The doses vary, usually 3 to 5 days, and then we usually start oral prednisone, 1 milligram per kilogram per day, held for anywhere from 2 to 4 weeks, and then taper over several months. Most of the time we aim to taper people off prednisone completely, but again, this can vary depending on the form of vasculitis and the clinical course. But the important thing is the taper is not set in stone. Someone who's having a lot of side effects, again, we can work around things. We just need to know about any problems. Also, the side effects depend on the dose of steroids and the duration of treatment. Most of us would define high doses as anything that's above 30 milligrams per day. So of course, more side effects. Medium doses are somewhere around 7.5 to 30 milligrams. And then once you're at 7.5 milligrams, it's really low doses, fewer side effects, but as all of you know, that's not zero side effects. And then, of course, some of the side effects are reversible, whereas some are not. Also important, as Dr. Chung discussed, we oftentimes end up having to prescribe other medications while people are on steroids to protect from some of the common side effects that we know about. So the Bactrim, Dapsone, atovaquone, these are often used to prevent a particular fungal organism called pneumocystis that can cause a pneumonia in people who are immunocompromised with prednisone. Important to note, it doesn't prevent all forms of pneumonia, just this particular one that people who are on high doses of steroids are susceptible to. The antacids are important to protect the lining of the stomach. Calcium is very important for bone health. We'll talk about that, as well as vitamin D, because the steroids can affect the absorption and metabolism of calcium and vitamin D. And then depending on risk factors, which we'll discuss again in a later slide, other medications may also be prescribed to protect the bones, which is one of the serious and irreversible side effects of steroid therapy. Also important to note that I know it's overwhelming, one with the vasculitis diagnosis and then all these other medications that we're adding, but some of these treatments are really while you're on the steroids to protect you, and some of them can be discontinued once you lower or stop the prednisone, but of course you would discuss that with your doctor. So this slide will look familiar to anyone who's been on steroids. These are very common side effects that are experienced and are often also dose dependent. Usually they improve with decreasing prednisone. They may not completely resolve. Some of the bothersome ones, of course, are the increased appetite, weight gain, the change in appearance from the puffy moon face, or sometimes the so-called buffalo hump at the back of the neck, water retention, skin changes, including stretch marks, or what we call striae, skin fragility with bruising, thinning, and then also side effects like tremors, muscle weakness, sleep disturbance, mood changes. Other serious side effects would be things like infection, bone health, which we'll talk about, the osteopenia, osteoporosis, but there's also another complication called avascular necrosis, which can happen while people are on steroids, usually at higher doses. We don't know what predisposes people, some people to develop it, whereas others don't. And it's actually from, we think, cutoff of the circulation of the blood vessel to the bone. So any new joint pain, usually the knees, hips, shoulders are the common areas that are affected. So any new joint pain in someone who's on steroids, we would worry about this complication as well. Then there's metabolic side effects like diabetes, cholesterol, stomach issues, which we talked about and can be helped by taking antacids, elevated blood pressure, the adrenal insufficiency, and then also eye-related things. So a lot of people on steroids get blurry vision, but sometimes it can also cause problems like cataracts, increased pressure to the back of the eye or glaucoma, and then also some fluid in the back of the eye. So what about long-term use? Because oftentimes our patients with vasculitis don't completely taper off prednisone or are not able to completely taper off prednisone. So the European League Against Rheumatism Task Force, which did include patients, set out to define conditions regarding the safety of the glucocorticoids with respect to these 4 side effects. So bone loss, diabetes, heart issues, infection risk. And what they determined is that this is low for people who are on 5 milligrams or lower of prednisone, high for anyone who's taking more than 10 milligrams a day of prednisone. And then for the doses in between, that it really varies on the individual and the risk factors that they have. So, you know, oftentimes we at least try to get to 5 milligrams or lower of prednisone if possible. There was also an interesting study that was just published. This was using Medicare and Optum database of over 200,000 patients. These were patients with rheumatoid arthritis who were also on other medications, but were also taking steroids. And they looked at the risk for being hospitalized with infection at 1 year. And patients with rheumatoid arthritis who were not on steroids, the risk was 8.6%. Whereas patients who were on steroids had a higher risk, but also what they saw was that this depended on the doses. So patients who were on 5 milligrams or lower, 11% compared to 8.6% in someone who was not on steroids. And then the risk increased up to about 18% in people who were on over 10 milligrams a day of prednisone. So again, the lower the dose, the better from our standpoint. And of course, we always try, if possible, to get patients off the steroids completely. So what about some of the strategies to help? Taking the medication as prescribed, we prefer once a day. If you're taking it, it's always in the morning. Sometimes we'll have people split the dose either due to side effects or because some people feel like the medication effects are wearing off early. If that happens, then the second dose is preferred to be in the afternoon or early evening. Like I showed you in that curve of the cortisol production in our body, the peak is really in the morning, and then as you get toward nighttime, the doses go to 0, so you want to keep it as physiologic as possible. Dietary factors, of course, easier said than done. The prednisone can cause a lot of increased appetite, cravings. It's important to keep healthy snacks around the house and avoid keeping unhealthy things like potato chips, cookies, etc. This can help with the weight gain as well as the risk for things like diabetes, which can also be from weight gain. Minimizing refined sugars in particular, and also monitoring carbohydrates. Salt is important to monitor as well because the prednisone causes retention of salt, and with the salt comes fluid and swelling. Fluid restrictions are important, especially in people who have kidney and heart problems, again, because of some of the side effects with the steroids. Activities are very important, both to help with the muscle strength and tone, with weight management, bone health. Again, this can vary depending on the form of vasculitis. There are people who have vasculitic neuropathy and may have weakness or other issues related to it. In that case, it's important to ask your doctor about physical therapy as well. We do have medications that can help with things like sleep, anxiety, depression. Again, these are things that can be discussed. Mindfulness, meditation practice can be helpful to help with some of the side effects, including sleep disturbance, anxiety. And then most importantly, again, unless we know that you're having problems, we're going to assume everything's going well. So if you are having side effects that are bothersome, it's important to contact your doctor, and we can always work on a safe way to taper the prednisone, sometimes faster than we typically do, but that would often require more monitoring. But there are ways to help. So some of the specific side effects, infection risk, this was always an issue in any of our rheumatic patients who are on these immune suppressing medications, and these were the precautions that we always recommended. This risk is higher on the high doses of steroids. Like I showed you, that recent study in rheumatoid arthritis found that it was lower in patients who were on less than 5 milligrams of prednisone, but still increased compared to someone who's not on prednisone. Important to avoid sick contacts if possible. The good hand hygiene, hand washing, appropriate vaccinations, but you cannot get live vaccines while you are on the steroids, pardon me. And then report any signs and symptoms of infection, also keeping in mind that the steroids and some of these immune suppressing medications can blunt your body's response to infection, like high fevers and some of these other things from being immunocompromised. So even a low-grade temperature would be considered significant in someone who's immunocompromised, and it's important if you're having any signs or symptoms of infection to get evaluated promptly and make sure you don't need to be on antibiotics. Also important, even though the steroids do suppress the immune system, they need to be continued. You do not want to stop the steroids suddenly, because again, even in our normal circumstances, when our body has an infection, the body actually kicks out more cortisol or produces more cortisol. So the bone health, the highest risk in terms of bone loss is within the first 6 months of treatment. So we want to identify risk factors for bone loss early. This side effect depends on what dose of steroids you're taking and also how long you're on it, the so-called cumulative dose. So it does add up over time. At the very least, it's important to get enough calcium and vitamin D. The recommended dose for calcium is 1,000 to 1,200 milligrams daily from all sources, so diet counts, and dietary calcium is preferred. There have been some studies suggesting increased coronary calcifications from supplemental calcium, although that's not clear. Vitamin D, the recommendation is at least 600 to 800 IU daily. I usually recommend at least 1,000. And then again, activity, so weight-bearing activity, physical therapy, depending on the clinical situation. And then there are other risk factors for bone loss. One is the inflammation itself. So, you know, we do want to manage the inflammation, but also things like smoking, alcohol use, those can be modified to minimize the risk of bone loss. This is a busy slide, but this is our American College of Rheumatology recommendations for the management of steroid-induced osteoporosis. And they break it up into risk factors based on age. So those who are less than 40 years of age compared to those who are over 40 years of age. And then stratifying them as high risk, moderate risk, or low risk. And you'll see there's a FRAX, which we'll come to on the next slide, that is used to calculate the risk, especially in people above 40. For those who are less than 40 years of age, having a previous osteoporotic fracture would be considered high fracture risk. And then based on the risk stratification, how long you're going to be on the steroids, we decide about whether you need to be on other medications as well to prevent bone loss, especially while you're on the higher doses of steroids or while you are on the steroids, depending on the duration of treatment. So this is the website for the so-called FRAX tool, which was developed to identify patients who would be most likely to benefit from treatment. And there are certain variables that we enter, including age, sex. It looks at the weight, height, and then other risk factors, including smoking, whether you are on steroids, and then what your bone density is. And then based on this, it gives you a risk or a score that estimates the 10-year risk for any major osteoporotic fracture. The thresholds that we use for treatment clinically are if you have a 10-year risk of fracture of over 3% for hip and 20% for any osteoporotic fracture. There are some limitations. It's using the hip bone density to calculate the score, whereas we know that the steroids usually affect the bone density in the spine. The steroid doses that it considers risk factor are low doses, not the ones that we're using. So you have to do some corrections. But again, it can be a helpful tool overall in assessing overall bone risk from treatment with steroids, and then also tailoring treatment based on that, because we do have effective medications to help with the osteoporosis and osteopenia. For the adrenal insufficiency, one of the other serious side effects from being on steroids long-term. So again, just a reminder of how the cortisol production is regulated, and the fact that when you're getting prednisone from the outside, so from medications, that it actually inhibits your hypothalamus and the pituitary gland to produce the normal hormones that it would produce to stimulate the gland. So again, this is one of the reasons we have to taper the steroids slowly. This is the major reason not to stop the steroids suddenly. And some of the symptoms to monitor as the prednisone is being lowered are symptoms of fatigue more than usual, muscle pain or feeling achy, flu-like, lightheadedness, and then also GI symptoms like nausea, diarrhea, abdominal pain. This can be variable, but usually more prominent as people get below 10 milligrams of prednisone. And sometimes if we're having difficulty tapering prednisone because of the adrenal side effects, not the disease activity, we may have our endocrinology colleagues help us with more additional testing to test this axis and how effective it is. And then sometimes also using other steroids that are needed for adrenal insufficiency. This was an interesting Danish study of 287,000 people, mean age about 69 years, who had been on steroids for close to a year. Most of them were for inflammatory conditions. And then what they looked at was the symptoms before and after stopping steroids. And what they found was that people who stopped steroids often had symptoms of hypotension and gastrointestinal symptoms that would be suggestive of adrenal insufficiency, and some of these were present up to 7 months after stopping the medication. So pretty common. The other thing is dental side effects. This is, to be honest, not on the radar of most physicians, although I do hear complaints from a lot of our patients. And this may be related to indirect effects of the steroids on dental health. So one being dry mouth, but also people can get the candida thrush. And then also the steroids do cause bone loss, including the areas around the teeth, so the maxilla and the mandible. And this is thought to be some of the reason why there might be issues with dental health. So the dry mouth can cause things like tooth decay. You can have gingivitis. The bone loss can also cause issues. So again, staying hydrated to help with the dry mouth, good dental hygiene, and then also important to get regular dental care. So to summarize, at the moment, the benefits of glucocorticoids still outweigh the risks in vasculitis for the reasons I stated. We're always trying to make efforts on using the lowest dose needed and for the shortest duration of therapy to manage active disease. Some of the side effects, again, can be mitigated, including things like bone loss. And then, of course, you're going to hear about newer strategies to minimize or even avoid glucocorticoid doses in some forms of vasculitis, which are underway. And with that, I thank you for your attention. I'm happy to take any questions.
Thank you, Dr. Kermani. Yes, this is a topic that is unfortunately near and dear to many of our hearts because many of us are on a lot of steroids, waiting for some of the questions to come in. How much is too much? How long is too long?
So that's a great question. So I would say long term, if you're going to be on it, anything more than 5 is too much. We try, but again, it depends on the individual as well. And for durations of treatment for vasculitis, oftentimes people are on steroids for months. So we're talking at least 6 months, but you know, again, that varies on the form of vasculitis, but usually we want to get people to the lower doses at least after 6 months or so, to 10 milligrams or less of prednisone ideally.
Okay, a couple of quick questions. What are some of the side effects of prednisone that do not resolve?
Yeah, so that's a good question. So the big ones would be cataracts, sometimes the diabetes, again, that can be irreversible. The bone health for sure, if you've had bone loss or osteoporosis, that may not reverse. And then some of the skin side effects can also persist, but they should improve as the prednisone comes down. So the skin thinning, fragility, sometimes that can linger a little longer.
Another quick one, has hair loss been associated with prednisone? I think many of us know the answer to that
yes.
one.
So I would say yes. I've heard about hair thinning, texture changes as well. Some of that may also be the stress of illness, but I would say yes, there's definitely some hair changes associated with the steroids and some of our other medications as well.
We had another question asking if there is a replacement to prednisone coming down the line, and I think that's what the next talk is going to be after the break. So I'm going to skip that one to a few others. One of the questions is about, is the duration cumulative? So if you've been on a high dose and then you're on a lower dose, but then you're back on the high dose, et cetera, how does that work in determining whether you had a high exposure?
Correct. So that's a great question. So yes, the cumulative dose would be calculated based on your daily dose of prednisone and then how many days you're on which dose. So that definitely adds up the longer you're on treatment with the steroids. And then also if you flare and have to go up to higher doses, then your cumulative doses are increasing.
Another question, if you've been on for a long time, say 5 or 10 milligrams, how can you get off of it safely?
So that can be challenging for two reasons. The first is making sure that the disease is not flaring as the prednisone is being lowered. So again, that's something you would discuss with the doctor. Usually if someone's been on it for years, we would come down maybe 0.5 milligram at a time every month or so, or even 1 milligram at a time. And then if the reason that we're having difficulty tapering prednisone is symptoms of adrenal insufficiency, which can be a problem if you've been on the steroids for a long time, then having our endocrinology colleagues help us as well.
Thank you. That's helpful. One more is sort of on the same line. What about the every other day, like alternate day dosing? I mean, I guess there's a lot of like preference among clinicians what they recommend, but what do you think about that strategy?
Yes, so in general, I haven't been doing the every other day. So you don't want to take it. In general, we don't take it one day, skip another day, but sometimes there'll be physicians who are trying to taper it very slowly and will say, 2.5 one day, 3 the next day. Again, there's a lot of different ways to do it. I try to keep it as simple as we can, but sometimes patients are the expert at tapering their own steroids if they've been on it for a while, and they know how to adjust it. So as long as they're doing it safely, I don't think we have data one way or another in terms of the safest way.
Okay, great. One final question is methylprednisone-induced hypersensitivity inheritable?
I haven't seen that, so I don't think so, but I don't know for sure.
Okay, well, thank you very much, Dr.
Thank you
Kermani.
all.